man-made disasters where there are wars and political conflicts. Some things there are tribal conflicts, economic blockades. An example are the countries in Africa and in our own region where there are economic blockades, and those lead to also disasters and loss of employment opportunities. So with displacement occurring due to these, the displacement also then brings changes in sexual behaviors. The individuals who have been displaced in large numbers to newer places will develop newer networks of sexual workers, and with high-risk individuals, there is change of power equation, and there are a lot of women in some displacements that happened very recently after the storm Katrina in the U.S. You found that very young women who got displaced went out onto the streets, and being unemployed, they were more vulnerable to sexual exploitation. There would be deprivation of sexual satisfaction for some people who have been displaced. There's anonymity that increases, and there's spendable cash sometimes more available. So displacement, it increases the vulnerability, and more so for women, and I think we all know these reasons. The displacement cycle essentially can be in two terms. When we talk about displacement, something comes to our mind is what is possibly happening in Sri Lanka, for example, at the moment. There are refugees, people either leaving the country and going and living abroad, or there are people who are internally displaced from one place to another, and they all form a common pool of conflict-affected populations. So these individuals would require an emergency setting of changing of environment. Now, if you were talking about condoms, talking about STI treatment in a conflict situation or a large massive displacement after tsunami, it really would be very difficult, because it's not only a health sector concern, it becomes a multi-sectoral concern. It directly is related to basic human needs of home and employment and food, and then comes the issues about public health with sexual diseases. So we then probably talk about, let's have a focus on multi-sectoral response even in emergency situations. I'm coming to almost the end of this presentation, just to make sure that we look at, when we are trying to alter the risk-taking behaviors, and you want to look at 20% of population that would fall somewhere in any of these categories, and either they are IDUs, either they are prisoners, either they are direct sex workers, or they are indirect sex workers, they're transgender, they're MSM, and there are shades of MSM. There are MSM, there's a die-hard MSMs, there are bisexual MSM, there are past MSMs, and there are future MSMs. So you can have all these categories of people falling in and out of the core group. So this is not cast in iron. So when we are dealing with groups of MSM, you know that they will be MSM not for 2 years and suddenly they become MSM, and back and forth and vice versa. And within that, what is happening in Indonesia, for example, that we know that IDUs, when they're sharing, then use needles and syringes. That is absolutely a very, very high risk behavior. And a lot of people would do it even if the needles and syringes the fresh ones are available. Now, if you look at what is happening in year 2008, look at the green bar. 2008, 40% of IDUs have been covered with exchange needle syringe program. Now, how long will it take to get to 95%? Because anything in public health has to have its threshold level. Now, in this threshold, we are talking about at least 95%, but even by 2010, this is government figure, the Ministry of Health figure, that by 2010, 80% of IDUs will be covered under the syringe needle exchange program. If you look at the prisoners, only 20% of the prisoners, a lot of them are actually IDUs, are covered under the intervention programs, whether they are condoms being available in prisons, whether other health strategies and health products are available to them. Similarly, 2008, we look at the green, we are looking at green bars that are 2008. In terms of sex workers, 45% is the coverage in terms of condoms being made available, in terms of their STIs, in terms of their other health needs. In case of transgenders, in case of MSMs, we're talking about only 8% coverage of men having sex with men and the other harm reduction strategies. So with these, we sum up with this final slide that is for Indonesia. I'm sure that other countries like Thailand and Malaysia and Philippines would have the similar pies. Only thing is the variation in terms of percentages. So when we look at Indonesian epidemic of HIV, almost 50% is driven by the IDUs. And we're talking still 40% coverage and intervention. So that entire environment of risk-taking behavior has not changed much. And the second large group is the clients of sex workers, 15% heterosexual, and then there are groups of MSM, and general population is 14%. So there is a lot of IDU transmission. At the same time, there is a lot of sexual transmission of the virus in Indonesia. So I think I've gone through this entire process of trying to rationalize what are the public health strategies that have been applied and how we can make them more efficient so that the strategies and the fundings are more or less available, but it's a question of being able to deliver and reaching the right people. So thank you very much again for this.
Okay, thank you very much, Professor Subas, for your straight presentation. And now we will move on to the discussion session. So we will have three groups discussion session. For the group A, we will invite the University of Diponegoro, University of Philippines, and University of North Sumatra. So be prepared for the students who wants to ask the question. So we will begin with the University of Diponegoro. Are you there, Diponegoro? Ms. Lintang, are you there? Do you have a question? Have you already connected? No? Okay. So we move on to University of Philippines. University of Philippines, do you have a question?
We don't have
Hi?
questions.
Okay.
Don't have questions.
Okay. So we move on to University of North Sumatra. Usu. Hello, Usu. Usu?
Yes.
Okay.
Hello?
Okay, so please go to the microphone. Usu, do you have question?
Ini mati masalahnya. Coba.
Yes. Hello.
Halo.
Yeah, we can hear you.
Maybe I have that one question for Professor Subas. They talk about the antiretroviral treatment. The first one use the transmission sexual rate. I asked the Professor Subas, how many that percentage you think that can effective to reduce the transmission sexual rate from antiretroviral treatment? Okay, thank you.
The connection is not so good. Can you ask again? Because it's kind of like a stop. Yeah, so it's not smooth here. Okay.
I want to ask
Can
you,
you-
sorry, yeah. You know, you look at the pictures, the resolution is not good.
Hello, Usu. Usu.
Okay.
Hello.
Okay,
Can you
hello.
Yeah.
And then dia bercakap the time dia breaking.
Come on.
Okay,
Usu. Yeah.
Okay. Okay, I want to repeat my question. My question is about the antiretroviral treatment. Professor Subas saying that will reduce the transmission, sexual transmission rate. I wanna ask them. I wanna ask him about how many percentage that you saying can effective to reduce the transmission sexual rate from antiretroviral treatment. Okay, thank you.
Okay, I think it's clear. Yeah.
It's a very good question. There are two ways to answer it. One is, you're probably asking what amount of coverage on antiretroviral should we have so that it reduces the occurrence of new infections in the community overall. And we are now talking of a global target that all the countries have signed with the UN, under the UN umbrella, and that is by year 2010, there will be a universal access to care, support, and treatment of and prevention to the individuals. In other words, all those people who have to receive ART will receive ART, because right now the coverage, for example, in Indonesia, the coverage of antiretroviral therapy is only 25% of those people who need to receive life-saving treatment. Now that has to increase by the target year of 2010, and that is next year, to 100%. Universal access is the motto, universal access of prevention, care, treatment, strategies and products available to all the populations across the globe. That is one way. The second side is probably on an individual basis, somebody who's receiving antiretroviral therapy, and what will be the probability of that person now infecting a person if he has an unprotected sexual intercourse, if he or she has unprotected sexual intercourse. And it has been worked out that the transmission probability reduces by 50 times. So last time we discussed the man-to-woman transmission probabilities and woman-to-man transmission probabilities, and this will further reduce by 50 times. So it will be a risk of transmission, but not very high risk of transmission.
Okay, thank you. And let's move on to Group B. So I will call University of Hasanuddin, Gajah Mada, and Udayana. So be prepared for all of you. So the first I will call University of Hasanuddin. Do you have question?
Yes, I have a question. The first, can you talk about any different about effectiveness intervention program to reduce sexual transmission in Africa region, US and Asian region like Indonesia? The second, how we explain that circumcision really can reduce infection HIV. Thanks.
Okay, thank you. So we move on to University of Gajah Mada. Do you have question? Gajah Mada, are you there? Gajah Mada? We cannot hear you. Do you have question? No? Or you cannot? Or is there any technical problem?
Because sometimes when they talk, dia pecah-pecah.
Gajah Mada? Okay. So we want to Udayana.
Yes,
Udayana,
we
do you
have. Do you hear me? Hello.
Yes, yes, yes.
We
Clearly.
have one question.
Oke, langsung.
Thank you.
Ya udah.
Hello. I'd like to ask Professor Subas regarding the last figure. Is it clear enough? Regarding the last figure, the population of HIV transmission in Indonesia. In this figure, IDUs comprises the largest percentage of all. Does it mean that they are the most vulnerable group to transmit or get infection, or just because the overall population of IDUs are bigger than female sex workers or clients of the sex workers? Thank you very much.
Okay, Prof. Subas. So the first about the effectiveness of the sexual prevention, yeah, and then the second one, circumcision.
Yeah, I think in terms of effectiveness of strategies to reduce sexual transmission, they work, and it has been shown that the estimates that were done, say for example for the global epidemic or the pandemic as we would call it, the estimates that were done 10 years ago are now being seen as excessive. A lot of countries now are recalibrating the size of their epidemic because the sexual prevention strategies or sexual intervention strategies have worked, and they are working. And I showed you one slide on Cambodia last time, which showed that even in sex workers, the sexual transmission being intervened by 100% condom use at every sexual intercourse has shown that the community prevalence of HIV has reduced from 3.6% to almost less than 1%. So yes, we have success stories, we have absolute evidence that the sexual transmission can be intervened, but it requires a very, very sound strategy and absolute good implementation and delivery of these services. The second question is about circumcision. And if you look at immense amount of evidence that has now been accumulated, not only from this region but even from Africa. There's a belt in Africa which is above the Sahara Desert, and you find that while the sub-Saharan countries which are having less level of circumcision because those are less, they are different religious groups, and then you have the northern Sahara countries where there are Muslim predominant communities, and circumcision is very, very common as a part of the religious practice, the size of the epidemic is 10 to 20 times smaller. And when this was being epidemiologically mapped, there were people who were looking at what else could have been the reason for a smaller epidemic in northern Africa as compared to southern part of Africa. And now when you have more and more evidence building from the Asian and the Pacific countries, it is reconfirmed that the consistent factor that seems to be is circumcision as protective in terms of transmission of sexual diseases, including HIV. And it has a biological explanation now, and also the biological explanation has been put to clinical trials. So I think there is no doubt in scientific minds that circumcision helps in preventing the sexual transmitted infections as well as HIV. The question is whether we want to use this circumcision as a therapeutic intervention to tell people that yes, once you circumcise, you will reduce your chance of transmitting or receiving HIV. But is that one of the mechanisms that we would apply along with major thrust on behavior change? Because sexual behavior change will also bring other high-risk behavior changes in individuals. The violence in individuals, the gambling in individuals, the smoking in individuals, and all that you can talk about use of substances. So it is a mixed bag, and yes, circumcision can be used and should be used. WHO does recommend as one of the strategies for intervening the HIV transmission in the world. The Gajamada group asked about IDU population, and you want to figure out whether 50% transmission at the moment is related to larger number of people in Indonesia who are IDUs. Now this is 50% or is a proportion of the infected population, and one would say that yes, possibly there is more transmission occurring in IDUs as compared to heterosexual transmission. Then it is fine. But you cannot say that there are too many people in Indonesia who are IDUs and that's why you have 50% of the infected people are IDUs. I think you have to apply this a little more carefully. And the interpretation of this will be that of the infected people, 50% are IDUs. But it has nothing to do with the overall universe of IDUs. Yeah?
Okay, thank you. So we move on to the last groups. So we'll invite Kuala Lumpur, Bangkok, UI Salemba, and UI Depok. So the first is Kuala Lumpur.
Yeah,
Dr.
good
Lau.
morning. Yes, good morning, Professor Subhash. I would like to know, in your slide, there was one slide whereby you mentioned that intensive treatment of sexually transmitted infection was not helpful, in particular Uganda, whereas it was okay for the other countries. Why was it so? What factors that caused Uganda to that sort of a pattern? And I want to know what does the short form VCT mean? Thank you.
Okay, thank you. Bangkok? Is somebody in Bangkok who wants to ask question? No?
There is a question from Asia, Bangkok.
Okay, you have Bangkok? You have question?
We have no question. Thank you.
Okay. And then we move on to UI Salemba. Salemba? Hello, Salemba? Hello?
I think we have no question this time. Thank you.
Okay, thank you. And then UI Depok. Hello,
Yeah.
UI Depok.
Hello, hello. Good morning, good morning. Hello. Can you
Yeah.
hear me?
Yes.
Okay. Thank you very much. We have maybe 2 or 3 questions. The first, uh, for reduce the HIV in disaster areas and emergency areas, what strategy for us to reduce this situation? It means if we have disaster, it means earthquake or tsunami. And then in Africa, Prof. Hira said that they have a good center for VCT. Are they a public health or a nurse or a doctor or social worker? And then the third question from my friend.
Thank you. First question is about the slide from Ministry of Health. Here the slide differentiate between transgender and MSM, and I want to ask about what is the point to differentiate these 2 groups in terms of intervention, because uh, as as long as I know they have quite similar sexual behavior. And then the second question is about female to female sex contact, because before the lecture before mentioned that vaginal secretion is one of the source of HIV virus, and then why female to female sex contact is not mentioned as like high risk or something, and is it because of lack of research in this area, or because of the low risk of female to female contact, sex contact? Thank you.
Okay, thank you, Prof. Subhash.
We'll go to the question raised by Kuala Lumpur and talked about what is the full form of VCT. VCT is Voluntary Counseling and Testing Services. It is a concept where an individual volunteers, considering that an individual wants to know his or her HIV status. So it is more of voluntary and goes to a specialized setting where counseling is first provided to an individual, for an individual to understand what the HIV test would mean to him and her if he or she turns out to be positive, and what is the kind of consequences of either of the sides of the results, so that an individual is prepared ahead of time before the blood is drawn for testing and also tested for HIV. So it is known as VCT, and that is the first milestone, for you want to say the cornerstone, or you want to say the important stone of intervening and changing the risk environment for this infectious disease. Yes, the second one is about mass treatment. Yes, this is the question that while we are talking about the clinical trials that showed that in areas where there is high HIV transmission and there is a lot of STI, you want to go and intervene and then give them treatment for their syndromes, and then go back and treat them again after 3 months, and maybe again after 3 months. So there are 3 levels of syndromic treatment for those who are found to have some disease. And when you find this type of the success that you have reduced the HIV transmission from the control group from 4.5% incidence to 2.2%,